All right, so I hope everyone enjoyed the breakout sessions. I know 30 minutes goes by quickly. And so we do have some time. We have about 30 more minutes remaining for the evening for a panel discussion. Tonight on the panel, we're joined by Dr. Pearman, who you heard from earlier, as well as Dr. Emma Barber, who was on the endometrial cancer breakout session, Dr. Daniela Mattei, who was on the ovarian cancer breakout session, and myself, who was part of the cervical cancer breakout session. Dr. Tanner, who is our Division Chief of Gynecologic Oncology here at Northwestern, will be moderating the panels.
Thanks, Dr. Strohl. I'm sure probably everyone, it's, I like the format of the mini-symposium. We can try to cover some topics in a short period of time, but I know I'm sure there's other questions that people have. I was kind of curious since while we wait for people to come to put in their questions for Dr. Pearman, your thoughts on just overall, like COVID fatigue, not just the overall stress, but like the long-term impacts of like this stressful situation on our immune systems and ability to just overall cope, and how to, like what that might do long-term in terms of like our overall health.
That's a great question, Ed, and I think that the jury is still out on that. There are definitely some studies going on that are looking at some of the immune markers of inflammation and other things and how that might impact long-term health. The one thing I will say just anecdotally in terms of the people that I've worked with is I think COVID has been much more difficult for people who are newly diagnosed with cancer, because they're still kind of trying to figure out the treatment scenario. They're still trying to figure out if they can trust us as their treatment providers. A lot of the not urgent procedures have been pushed back. And so that's been a huge stressor for people that are kind of newly diagnosed. But for people who I've known who've been diagnosed years ago and have been going through this kind of managing it as a chronic illness, I think it's been, they've been able to sort of say like, you know what, the rest of the world kind of finally gets it in terms of what I've been going through. I had someone tell me a couple of weeks ago, my family and friends have been accusing me of being like overcautious and why can't we get together? And I mean, your immune system's not that bad, right? Like, why can't we get together in person? And now they finally understand what it's been like to be us, me and my family for the past like 3 or 4 years. And so I think it's been interesting just to see kind of how our patients have dealt with this in different ways over time.
That's great, thank you. Yeah, I think one of the things that we deal with, I think, are not just patients who are on active treatment, who are like dealing with the stress of the current environment, but also patients who are in surveillance. And I get a lot of questions about about fear of coming to the hospital and like, am I still at risk and what my risks are. I don't know if anyone would like to talk a little bit about that topic, about I have a few thoughts on it. I'm just curious if anybody has any thoughts about, surveillance and how this has changed that, regardless of kind of what kind of cancer a patient might have.
Well, I'll jump in here. I think we've seen an increase in, the telemedicine visits, which have been great, especially in the initial period. However, for many of our surveillance visits, we require an examination, which obviously it's needed to be done in person. What I have been amazed at myself as a physician is the fact that our cancer patients have done so well and have stayed kind of free of infection over this period. And, you know, when people come in, they always comment on, you know, they feel very grateful that we as physicians and nurses are present in clinic, and they commend us for that. But I personally feel very safe in clinic. And I don't know if other providers have the same feeling, but I'm kind of grateful. And I think that our cancer patients are just so careful. They are used to be taking precautions on a regular basis. And perhaps that might explain why their rates of infection are lower, protecting us as well.
Yeah, I've really tried to look into data on this about, you know, infection risk for patients that are like longer term survivors and what the risks are. And there's not, I don't know if anyone else has noted, I've tried to find data about this. There's a small amount of data about a study that was just published in Women with Breast Cancer looking at immune function, and that it seems like there may be some delayed immune function for up to a year after treatment, but we don't really have longer term data beyond that, for better or worse. And you know, there's so much that we don't know right now. Things that we should have probably answered, you know, didn't require a pandemic to answer these questions, but you know, now they're more pressing about, you know, how does a situation like this impact, you know, overall health and risk long term. Is very, you know, there's just so much that we don't know yet. Why don't we try to maybe address some specific questions? I think one question that perhaps I'll direct to Dr. Matei is how has the COVID pandemic impacted clinical trials, enrollment in clinical trials?
Yeah, that's a very good question. We've relied a lot on clinical trials for our patients that have more limited options, being at the end of treatment. And during the pandemic, a lot of trials have closed. We have maintained some therapeutic trials open, but overall nationwide and in our cancer center, accrual to clinical trials has declined significantly, perhaps to about 25% compared to baseline. But the accrual is now picking up again, and most of our trials are reopened. It's been a challenging time. It's always very difficult to recommend or to accept participating in a trial in these unknown times. Some of the trials require more visits to the hospital, but I have to say that I have had patients that have done trials during this difficult period, including trials that required coming to the hospital twice a week. So I'm really grateful for those patients who have participated. But it's been difficult on both sides.
I'm going to ask a question. I'm going to kind of roll two questions together. There's a couple of questions in the chat about maintenance therapies and how long for patients to stay on maintenance therapies. Both a comment about PARP inhibitors and bevacizumab, whether patients should stop those treatments at some point or continue them indefinitely. I don't know if Dr. Barber or Dr. Strohl want to handle those questions.
Sure. I mean, I think, you know, in terms of PARP inhibitors for maintenance, there have been multiple studies, and these studies are, you know, coming out all the time. So the initial studies, like SOLO-1, kept people on for 2 years. And so that's sort of what we have data for. PRIMA came out in December, and that kept patients on for 3 years, right? So now, you know, we have data that up to 3 years is safe. There are people that will sort of say that the, you know, sort of curve separation between people that were on the PARP inhibitors in SOLO-1, so they kind of stayed separate for 2 years, and then once the patients stopped the PARP inhibitors, if the drug was still working for a longer period of time, they would stay at the same distance apart, versus if, you know, you needed to keep taking it for it to work, you'd say, oh, now they're coming back together. The survival benefit isn't really staying, and we don't see that. So that suggests that it might be fine to come off at 2 years or to come off at 3 years. We have no data for patients sort of taking them indefinitely in the frontline setting because that hasn't been studied yet. In general, you know, obviously recurrence of ovarian cancer is a really big consideration, but these drugs also do have some implications for bone marrow, for risk, you know, rare risks of like leukemias or myelodysplastic syndromes. And those risks, you know, may be increased in people who are on them for a long period of time. We just don't have the safety data. So I think kind of unknown data for both 2 years after initial surgery and chemo, and data for 3 years, not really data yet beyond that in terms of safety.
Yeah, I agree. I think that in some ways the PARP inhibitor data it's sort of an easier and a harder question because we don't have data for very long time, but some patients tolerate the drug really, really well. And we love to see them doing well on it. But we also have this leukemia risk that, you know, at some point one would think that risk associated with long-term PARP inhibitor use might start to shift the balance of risk and benefits, but we just don't have the long-term data yet to address that. As far as there was another similar question about bevacizumab, and you know, a lot of the data for that really looked at using 1 year of maintenance therapy. I do find that there are perhaps more patients that start to develop kidney issues eventually with long-term use of bevacizumab, but it's very individualized, and you know, I think it's tough to make a specific call about that, but that is one of the things that we do notice with long-term use of bevacizumab is that, you know, issues with high blood pressure and kidney issues.
I could make a comment. It's really very difficult to determine this along the length of maintenance therapy. But for example, in other tumors, like in breast cancer, similarly, Herceptin has been studied extensively. And the same question comes up, how long? So there have been studies that looked at 1 year versus 2 years, and 2 years was no better than 1 year. And in fact, 6 months in some studies was just as good as 1 year. So this is something to continue to be studied.
I have another question. This is the hard question. I one that I think that we all have dealt with over the last 6 months, and perhaps to have Dr. Pearman to start with this. But you know, I think that we have patients that may be dealing with a life-threatening illness in a time where they're not able to visit with their family and friends. And, you know, for patients that may not have a curable cancer and may have a more limited time, how can someone cope with realizing that there is limited time, but also not being able to see people that they care about and spend time with the people that they care about? It's a really hard thing right now.
Yeah, that's a great question. And I think the most important thing is communication with your treatment team to evaluate the risks and the benefits of traveling, of seeing family. So I actually just met with someone yesterday who has a son who's living in France, a daughter who is living in Boston, and another daughter who's living on the West Coast. And so one of those siblings can actually quarantine for 14 days after getting to Chicago, but the other two can't. And so he's decided that he will spend time with his daughter that can actually come to Chicago, quarantine, and then see her. But his other two kids, he's just not willing to take the risk at this point. And so I think it's just, you really need to communicate with your nurses, your doctors, and figure out what is the most important thing and what risk benefit analysis you have, because I think that really differs person to person. Some people are willing to take a little bit more risk in terms of their COVID status, and other people want to be really, really conservative. So I just think it's important to like open up the lines of communication among your providers and also your family.
So I'm going to try to get to all the questions in the chat. We'll go to a question about endometrial cancer, and perhaps for Dr. Barber. So patient had a question about genetic testing for someone who had a stage 1 endometrial cancer 7 years ago and then recurred a few years later. And was wondering about Lynch syndrome testing and what circumstances we recommended. And then maybe perhaps just to mention again about how that impacts treatment.
Yeah, I think this is a great question. So an important thing to know is whether or not mismatch repair proteins were checked on the tumor at initial diagnosis or at recurrence. And here at Northwestern, I know at least, I think it's been 10 years, maybe a little bit longer, that every endometrial cancer patient is the mismatch repair proteins are tested on the tumor. And so if somebody is over 50 and their mismatch repair proteins are normal, there's not any more specific genetic testing recommended unless there's extenuating circumstances, family history, some other thing that's kind of tipping us off. If a patient is under 50, it doesn't matter what the mismatch repair proteins are, it's recommended that they undergo genetic testing, just because that's a young age and we don't want to miss a genetic reason. There are some other caveats to the mismatch repair proteins being abnormal, but the patient not needing germline or blood testing for genetic reasons, something called hypermethylation testing. But in general, over the age 50, if the mismatch repair proteins are normal in the tumor, barring really extensive family history, there's no genetic testing for Lynch syndrome that would be recommended.
I think one of the things that also is really important about this is the treatment options that we have available with immunotherapy, and we had briefly touched on this in the ovarian cancer session that so DNA mismatch repair protein abnormalities we can see them in the tumor, but that doesn't necessarily mean Lynch syndrome. A lot more women will have abnormalities in that, especially with endometrial cancer. We don't see it as much in cervical and vaginal vulvar cancers and ovarian cancers. For example, in ovarian cancers, maybe only 2% of tumors will have abnormalities. We will sometimes test for this when we do genomic sequencing for patients, so we'll send a piece of the tumor off for testing. But unfortunately, so this kind of testing, regardless of what type of cancer there is, this is a new way of thinking about treatment in terms of targeted therapies that regardless of what type of cancer someone has, if they have abnormalities in DNA and mismatch repair proteins, they'll be eligible for immunotherapy with pembrolizumab. So that's pretty exciting from our standpoint, to be able to offer a kind of a disease agnostic treatment for cancers, and probably the direction that we'll be heading. So this kind of testing is especially important for endometrial cancer because we see it more often, but it really is what we'll be hopefully seeing for lots of different types of treatments for different cancers in the future, as well as for Lynch syndrome testing for genetic testing. So let's see, what should we address next? So there was a question about secondary surgery for ovarian cancer. Maybe like under what circumstances that would be recommended. I know it was addressed to me, but maybe I'll pass this to Dr. Strohl to address this question.
Thanks, Dr. Tanner. I think this is a discussion that we have at tumor board and in clinic relatively frequently when we have a patient who may be eligible for a secondary debulking. So I think when we think about ovarian cancer in the primary setting, the treatment is always a combination of chemotherapy and surgery. And then in certain circumstances, there may be some ovarian cancer patients that when they recur, their cancer may be amenable to a secondary surgery. And more recently, we've had studies addressing this exact question, looking at are there certain patient characteristics that benefit from a secondary surgery, or should we just give chemotherapy in this situation? And I think there's several studies, there's different studies that can help you find the answer that you're looking for. But the summary or overarching theme is that there are a select group of patients that may benefit from a secondary cytoreductive or secondary ovarian cancer debulking. Typically, these are women that have had a long period of time between their first treatment or their first completion of their first therapy of the combination of surgery and chemotherapy. Their way in which their cancer comes back is amenable to a surgery in which we can achieve what we call an optimal cytoreductive surgery, where there's no residual cancer at the time of surgery. And the patients are otherwise, we feel, will be able to recover from that surgery and receive additional chemotherapy. Because again, in that scenario, the treatment would be a combination of surgery and chemotherapy. Yes, there are certain situations in which a secondary surgery is beneficial, but it's typically a very select patient, and it's an individualized decision with each patient.
Great, we're getting close to the end here. Let's go with another question about PARP inhibitors. I know it's a common topic. So this is a question for Dr. Mattei about looking at the data about efficacy of PARP inhibitors depending on the dose, if a patient has to have dose reductions in PARP inhibitors. And we'll keep it general because I think this is a question regardless of which PARP inhibitor a patient is on. Does a dose reduction impact the effectiveness of the treatment?
I'm not aware that there is a lot of data on this subject of relationship between response and dose. Obviously, we have to keep our patients healthy and have a good quality of life. So the dose that is tolerated will be the dose that will be used as maintenance. For some of the PARP inhibitors, the initial doses have been used, like a higher dose has been recommended, but it turns out that in fact a more moderate dose is the one that's tolerable, and that's the one that we're using in clinic. Anyone else has other thoughts?
I feel like this is a question that applies to every treatment that we have, right? Sorry, Dr. Strohl.
Yeah, I think that especially when we're thinking about PARP inhibitors, and this gets a little bit back to the maintenance discussion, is that when you're on a maintenance medication, we want you feeling as good as possible and really optimizing quality of life. And sometimes that means reducing the dose slightly so that that some of those side effects can be mitigated, so that we can continue to give the medication and patients can benefit from it. So it's really a balance, and I agree with Danielle or Dr. Mattei. There's really not a significant amount of data to suggest that there's a lower limit of efficacy with PARP inhibitors, and the trials included dose reductions built into them. So I think that it's a balance between being able to take the medications and finding a dose that's right for you.
Great. We'll have one more question for Dr. Mattei. This is also a very good question. How do you decide whether patients should do standard therapies versus being on a clinical trial?
Yeah, this is also a very good question. It's truly individualized, and it really depends also on the clinical trial. One thing to know for patients is that the standard therapy will always be there. The clinical trials, it's kind of a window. It could be open today, and another slot may not be available, 3 months down the line. It's always a kind of a discussion going back between the physician and the patient. Clinical trials, most of them don't, some of the phase 1 trials, we don't even know if they have any activity whatsoever. So they are not a guarantee of success, they are a question. They do require commitment on the part of the patients. We're very grateful for, it's time commitment, additional blood work, maybe more testing. But we could never advance medicine without these trials. We could not help the patients of the future without the trials. So it's something that I'm personally very committed to, and I'm very grateful that so many of our patients are willing to participate. Sometimes it's also like how interesting the drug is, but you never know. A great drug may not help a particular patient. And then, some drug may work for like 8 years or something. It's always that hope.
Thanks, Dr. Mate. I think that's about all the time we have. So I'll turn things back over to Dr. Strohl to wrap up.
Sorry, I thought I got kicked out completely. I just wanted to say thank you to everybody for joining us tonight. I think certainly we miss seeing everybody's faces. And I know I missed out on being a part of the other breakout sessions as well, and hearing everything that everybody else has to say. I learned just as much as everyone else does on these nights where we get to get together and hear from each other. And we certainly missed hearing the voices of the patients as well. So hopefully next year we'll be able to have an event in person so that we can celebrate everybody together and look forward to the future together. I think that if you have additional questions regarding the program, you can contact us directly at cancer@northwestern.edu. If you would like additional information about any topics that were discussed tonight, you can visit our site at gynonc.nm.org. Or if you want to speak to our care team, you can contact us at the Cancer Center. It's 312-695-0990. And if you want to check out the other breakout sessions that you weren't a part of, or you tuned in late or had to take off a bit early, there will be video recordings of today's presentations available at the website on the slide, which is www.cancer.northwestern.edu/events. That will be up in the coming weeks. So again, thank you everybody for joining us tonight. Stay healthy, stay safe, wear your masks, and vote.